I am Graciela Rojas. I am psychiatrist, professor of psychiatry at the University of Chile, and I am the director of this project, a collaborative computer-assisted cognitive behavioral therapy for psychological treatment for depressed patients with chronic diseases at primary care. So in my presentation, I am going to tell you very little about our Chilean health system, about the primary care programs, some epidemiological data, and the new study protocol. So in Chile, healthcare is provided by a mixed private and public system. The public system is the public health system provides services to almost 80% of the whole population, including almost all lower socioeconomic groups. The public health system is organized into 29 health districts, and this system was established in 1952 and has a network of primary care centers and services, and has implemented many successful public health programs, for instance, vaccination program and chronic disease programs. There are marked socioeconomical and geographical inequalities in the access to specialized health services in Chile. So our population is around 17 million persons, and there are more than 23 million cell phones. 30 million people have mobile connection with 4G, and 3 million people have fixed internet connection. For every 100 inhabitants with mobile telephone services, 96 connect to the internet. So the access to internet is less unequal than the access to health specialized services. Chile is a country with an above average digital connectivity, and the access to digital technology is less unequal than the access to specialized health services. So this protocol had the general goal to compare the effectiveness of a collaborative computer-assisted cognitive behavioral education and psychological treatment versus enhanced usual care to treat depressed patients with hypertension and or diabetes in primary care clinics. The specific goals is to compare remission and recovery rates of depression in both groups, to compare health-related quality of life, to compare adherence to treatment, to compare physical outcomes like values of blood pressure and other glycosylated hemoglobin, and to compare satisfaction with treatment in those patients treated intervention clinic with those patients treated in the control clinics. The study is using now a mixed method design that integrates qualitative component to support the intervention design and its evaluation, and with a quantitative study to assess the effectiveness of the design intervention in comparison with enhanced usual care to treat depressed patients with hypertension and or diabetes in primary care clinics located in Santiago, the capital of Chile. The study sample frame is the primary care clinics located in the capital, Santiago of Chile, that have a running cardiovascular and depression program, have access to internet, and accept to participate on the trial. So in total, 8 primary care clinics will be selected and randomized, 4 for the intervention arm and 4 for the control arm. The quantitative study will assess the effectiveness of the design intervention in comparison with the enhanced usual care in depressed patients with hypertension or other diabetes. That is a single blind cluster randomized controlled clinical trial. So the participants are people older than 18 years of age, suffering hypertension and or diabetes, attending to these 8 primary care clinics. The inclusion criteria are being 80 years or older, having the diagnosis of hypertension and or the diabetes at the primary care clinic, and having a PHQ-9 score of 10 or more. And the exclusion criteria are alcohol dependency, abuse of psychoactive substance, bipolar disorder, current treatment of depression for depression psychotherapy, severe hearing, vision, displacement, or cognitive impairment, resident in a long-term care. So in each of the 8 selected primary care clinic, patients that are attending the cardiovascular disease management program will be approached while they are waiting for consultation, or patients, consenting patients will be asked to complete the PHQ-9. Those patients with the score of 10 or more will be invited to a baseline assessment to evaluate inclusion and exclusion criteria. And those patients who at baseline assessment meet the inclusion criteria and do not meet the exclusion criteria will be included on the trial. So 4 clinics will be randomized to the intervention arm, that is the collaborative care program, and 4 to the control arm. And the randomization will be done using computer-generated random numbers. So patients in both arms will be invited to use a web page for the project, and this page includes information about hypertension, about diabetes, depression, and about healthy lifestyle in an attractive visual format. And the control arm will have the usual care treatment. This treatment in Chile includes medical and psychological treatment and referral to psychiatric service when it is necessary. So the patients in the intervention clinic will receive the usual clinical and medical treatment and a complex intervention that have many components. The computer-assisted cognitive behavioral education and psychological therapy that will be delivered by trained primary care psychologists. There are 8 sessions. The topics covered will include information on hypertension and diabetes, care for chronic diseases, healthy lifestyle, self-care techniques, symptoms and causes of depression, treatment options, problem-solving techniques, and other cognitive-oriented strategies to face negative thought. Psychologists will be trained during 3 days to administer the intervention, and this training will include management of chronic patients and motivational techniques to improve adherence to treatment. So we have developed a manual for the intervention that looks like this. And in both groups, the assessment will be carried out at the baseline 3 months, 6 months, and 12 months after recruitment. The primary outcome measure is depressive symptoms measured by the PHQ-9 at 3, 6, and 12 months after randomizations, and the secondary outcome measures will be also measured at 3, 6, and 12 months after randomization. Health-related quality of life will be measured with the SF-12, values of blood pressure and other glycosylated hemoglobin, and use of services, including the use of different components of the intervention, will also measure at the 3, 6, and 12-month follow-up. Satisfaction with treatment will be measured at 3 and 6 month follow-up assessment. So for the sample size calculation, we anticipated that 40% of people receiving enhanced usual care and 60% in the intervention group will recover in 3 months. And each study group will require 156 patients distributed into 8 cluster primary care clinics of 39 patients for each of the 8 clinics. We need 312 depressed cases. For the analysis and presentation of the results will be in accordance with consort guidelines for cluster randomized clinical trials, with the primary comparative analysis being conducted on an intention to treat basis, and due emphasis placed on confidence interval for the between arm comparison. Initially, we will conduct descriptive analysis to assess the balance between the 2 groups. The primary analysis will employ multi-level, multivariable linear regression to investigate difference in the PHQ-9 score between the groups at 3, 6, and 12 months after randomization, adjusting for the baseline outcome variable score. Sensitive analysis making different assumptions will be conducted to investigate the potential effects of missing data, and similar analysis will be done for the secondary outcome measures. The effect size will be measured by a ratio between the values after and before the intervention. So we will do a post-intervention qualitative study that with the purpose of collecting feedback information about the intervention, focused on the experience of study psychologists, primary care professionals belonging to both arms of the trial, and patients who participate in the intervention arm. With study psychologists and primary care professional around 20, the specific focus will be on comparison between the collaborative care program and the enhanced usual care, difficulties and experiences in their relationship with the patients during the treatment, differences between patients who improve and not improve their adherence to the medical treatment and their depressive symptoms. With patients, the focus will be on personal meanings and experience of presenting and not presenting the symptoms, triggers and context of symptoms and non-adherent behavior, lifestyles, habit and support network, personality and relational styles, helpful and hindering aspect of the treatment. The data collection procedure will be 2 focus groups with primary care professionals of both arms of the trial, 2 interviews with the study psychologists that facilitate the intervention arm, 10 interviews with patients that benefit from the intervention, and 10 interviews with non-improved patients. A grounded theory-based approach will be used to compare subgroups within the whole sample. So thank you very much for your attention. I think you may be all very tired because we had a very long session today.